Wrestling Performance Podcast. I'm your host, Doug Kechijian, and today I'm joined by Bill Hartman. Bill is a personal friend and professional mentor, and he's one of the people that I trust most when it comes to topics like critical thinking, clinical reasoning, and clinical education. Bill is a private practice physical therapy owner in Indianapolis, Indiana, where he works at IFAST, Indianapolis Fitness and Sports Training, and he has a ton of experience rehabbing and training athletes in a variety of settings. All right, Bill, thanks for coming on. So you've been on here before, and we've had a lot of private discussions about, models and clinical reasoning. And these are things that maybe can't be captured or obviously answered in any kind of format, let alone an hour podcast. But I also know that you're also a big fan of, mixed martial arts and of Bruce Lee. So I think a good analogy to get this going is the idea that, Bruce Lee created this system of systems that he called Jeet Kune Do, and he's famous for saying, take what's useful, disregard what's useless. Right. So when it comes to, if we kind of liken whether it's like treatment in a clinical scenario or coaching in a performance scenario where you have this complex, chaotic environment, the ideal is this flow state where you're just kind of going. And in Bruce Lee's case, you're just fighting and you're not thinking about, okay, I'm doing Western boxing now and now I'm switching to jiu-jitsu. It's very seamless, but do you think that even in the clinical setting, that flow state being the ideal where you kind of come to transcend these models and these different constructs, do you think it's possible to achieve a flow state without compartmentalizing information and breaking them down into these very constrained boxes? So in other words, I guess fundamentally I'm asking, is it possible to learn without doing that, in your opinion?
That's a really good question. The way that we build our understanding, I think, has a lot to do with why we compartmentalize in the first place. So it is a defense. That's the one thing that we want to recognize about compartmentalization, is that it is uncomfortable to try to hold multiple ideas in your head at one time. And so compartmentalization makes that easier for us. So it is a reliever of stress. It is a protection against trying to rationalize two potentially useful, potentially equal elements and put them to use. Right. And so again, I think that that's what we have to recognize first and foremost, is that if we do recognize things as being so different, then the first strategy would be to compartmentalize. If we can start to look at things as one big entity, where people would say that it would be more integrative, right? So Jeet Kune Do is an integrative fighting system of many systems that were brought together. And instead of seeing them as separate things, if we can start to see things as being more unified, then I think that we don't have to do that. But I think it's also very, very difficult to build such a model from the ground up, that it does take a great deal of time, and it is still uncomfortable. All you have to do is be a clinical instructor on the first go round, and you will recognize the difficulty that students will have of grasping things in the reality of the clinic, because as we as practitioners went through that ourselves, we become more comfortable, because what we see is many things having done things through repetition and an orderly fashion that allows us to, at a glance, we see something that it would take the student 7 or 8 different looks or different perspectives. We see that as one, but that was done through a great deal of investment of time and effort, which again, it's uncomfortable. And so I don't think we have to compartmentalize. I just think it might be one of those things that we do to try to make life just a little bit easier.
Yeah, because it's very easy to look back retroactively at something like even traditional martial arts. I remember, and I'm sure you remember, like the original UFCs, where like every guy had a style, and it was like the Taekwondo guy versus the Jiu-Jitsu guy versus the barroom brawler. But I don't get the sense, and even going back to like Bruce Lee, that he never badmouths. He doesn't say like, hey, judo's no good, jujitsu's no good, kickboxing's no good, Western boxing is no good. Like, I don't know if Jeet Kune Do would have been possible without those things. And I'm sure that there's going to be a point where somebody, you know, the next Bruce Lee is going to look at Jeet Kune Do as being overly robotic and constrained. So I guess, you know, there's always like this idea of progress with models, but I think that, and you've talked about this, like, I guess, how can we be like agnostic about models? Because, and you and I have had private conversations where we've talked about, okay, like we can bash on certain things, but even going fundamentally back to the concept of models, like, and you touched on it, but what's good about them? Because it's very easy to say, okay, like the model doesn't account for all these contextual things, but why are we fundamentally even using them in the first place? You mentioned kind of safety. Can you elaborate on that a little bit?
Well, again, it just becomes comfort. It's like trying to hold multiple ideas. So if we associate everything that we learn with what we have previously understood or what we think we understand, then to add on to that, it's always the comparison. And so again, so there's an element of compartmentalization in that. It's like, I know this, I understand this, I am comfortable with this. For me to superimpose something on top of that, I have to see the relationship to make it comfortable for me to take that bit of information in and then eventually to utilize it. If I see it as too extreme, so if I see, you know, the battle between systems, then that's where the discomfort really starts to arise, and then I become defensive and I push that information away, even though something about that may have been useful. So what we want to do is we want to see these things like where the commonality lies. So if we're talking about clinical reasoning, or we're talking about movement, or we're talking about working with humans, what we want to say is like, okay, so if I have these two competing systems, but they're both working with the same system, how do I draw these things together? And so then that becomes this commonality. So again, if we're in the clinic, we're working with the human and movement. It's like, okay, how does this system see this representation of movement? How does this other system see this? And then can I draw some commonalities? The thing that you got to be careful of is just because someone has a system doesn't mean that it is valuable. And so we have to be very, very careful of that. And that's something that you learn how to filter out, I think, over time is where I build this bigger and bigger and bigger base of analogy, and I can identify things that would be in extreme conflict with that, where and you've heard me say this before, it's like, you know, if you go to a course or something, and if they provide you some piece of information, if you don't have a defense against that, you will absorb that as a fact. Like, you will take it in. And so that's a big part of this is constantly building your base of analogy. And I think that probably what we're talking about more than anything else is an evolution of learning, really. It's like, I have to learn something to compare to. And so maybe initially we're looking at these things from a compartmentalized structure. And then as I start to recognize commonalities and my base of analogy does grow, now so does my filtering system. Now my BS detector, you know, is much more accurate, if you will. And you know, if we want to use Bruce Lee as the example, he started with a martial art. I mean, it was a very, very specific, rigid martial art, and it was his recognition of that rigidity, even though he may have been superiorly prepared within that art to defend against any number of things. He recognized that his restriction and depth of understanding of that one art allowed him to recognize the fact that there are weaknesses in restricting that perspective and saying that this is it. We can never say that. There is always a better model available to us. We just either haven't been introduced to it or we didn't recognize it ourselves yet.
Yeah, and there's a lot there to digest. So the first thing you're kind of alluding to is all these models are kind of like dots on the map. And what you're talking about is an overall framework that allows you to connect those dots. That's essentially the BS filter that you're talking about.
Right.
Going back to like the Bruce Lee analogy, you know, he started out in Wing Chun Kung Fu. And I think that what made him evolve was that he got in a lot of fights and he realized the limitations of that one model because he didn't start out fighting. He started out learning a traditional martial art. Then he got into fights where he realized like, wow, like there's other things I have to be prepared for. And we're talking about like the clinic, and I know people always talk about clinical reasoning. I don't know how much it can actually be taught in an academic setting because you don't have the context. You haven't gotten in enough fights. You're talking about like you're seeing similarities, right? Because it can be very hard initially. I remember how overwhelming it was. You know, you learn about the 10 different kinds of knee patients you're working with. So it's like the knee replacement person, the ACL person, the meniscus person, the patellofemoral tracking person. After a while, you kind of realize that they're fundamentally all really the same. They just have different constraints.
Right.
So, and I think people get frustrated, myself included, because there's a point where like, you know, I'm going to all these courses. I just wanted to expedite the process. But what really did it was, I think, just treating people, kind of being in the arena, so to speak, and then just making sure that I wasn't so dangerous that I was hurting people. But you kind of have to make those mistakes. So, I mean, we started, and we're having kind of like an ideal, you know, conversation here. We're not worried about like regulatory constraints and legalities. Just we're starting out utopian, right? But
right.
in this utopian environment, I mean, if you wanted to clone a PT that could work for you, that you could sell your practice to,
right.
Would you start out having them take classes in an academic setting, or they just watch you treat for 6 months or a year to get that context? And then, so do you think we should be starting with the theory first and then the practice and then the theory to get context? Or is there kind of a hybrid that we should be doing? Because I think that the traditional programs are very heavy on theory initially, right. You have no context, and then you have to almost relearn that language in a contextual environment.
Right. So here's the dilemma that you run into. And again, I had my 25th student in the last 8 years that just wrapped things up not too long ago. And the simplest of things that you would expect somebody to know and understand have been forgotten. It's not their fault. It's just the way that the programs are structured, where they throw, you know, heavy duty doses of physiology and gross anatomy at you. And then it's like, okay, here's where stuff is. Here's how this stuff works as a separate system. And then when it comes time to integrate all that stuff, they have unfortunately, because of the way that they learned it out of context, it's very difficult for them to remember or apply it. And so what we're talking about here is the difference between the stuff that you can write down, which is explicit information, and then the tacit, which is very, very difficult to explain to anyone because it is experiential in its foundation. And so without that, without the tacit, then you're just regurgitating stuff that will seem meaningless to you. Now, you can get the answers right on the test per se, but when it comes time to the real test where you're working with the individual and you're dealing in a complex atmosphere where there's tremendous number of influences and a tremendous number of unknowns, then the book learning, if you will, has a limited value. It doesn't mean that it has no value, it just means it has a limited value. And so I think that your mention of this hybrid approach of sort of, it's kind of OTJ when you think about it. It's like, you know, it's like, and you've heard me talk about the plumber thing before too, where they learn primarily through an apprenticeship model where they are literally on the job from the get-go. And I think that if we were ever going to evolve the profession that we are involved in, with the scope that we have, it would be so much more ideal to be in the clinic from day one and to see these things in representation. Now, when you do learn anatomy, you're learning it within a context, and then it becomes more meaningful. And so that information is then retained because, again, we're attaching something that's very, very powerful, which is this experience. So there's emotions involved. Which again ties a lot of things together, which, you know, when it's almost like a forced upon you scenario of regurgitation, where it's like, okay, here's a piece of information. I want you to memorize this piece of information and then spit it out on the test. And if you spit it out the right way, the way we want it to, you'll get a really, really good grade. When the reality is, it's like the good grades are basically you understanding how to manage outcomes in a clinic. And I won't say to be successful, because you just don't know whether you're going to be successful or not. The goal is to take new information, be able to integrate that into the situation, and then take the next step forward as successfully as you can. And if you can't, then obviously to determine, well, is there a reason that I cannot move forward? And then that's when we start to send people to other people, right? So I have to send you to the doctor, or I have to send you to some other form of profession that may have an influence in this situation. And now you become the true manager of the situation.
So that's a great segue into the next thing that I wanted to talk about. Within the confines of like physical therapy and rehabilitation, we're learned a certain way of diagnosing, and it's typically the medical model, because there's, like, for a variety of reasons, many of them political, physical therapists want to identify as medical providers, so they diagnose like medical providers, when in reality the scope of practice of at least a non-MD is that they can't directly treat or address pathology. All they can do is try to maximize function within the context of that patient's goals and values, right? And then things like pathology might be a constraint, but you're not addressing it directly. So, and to me, this is kind of where we start from, because if your diagnostic framework or constructs are, I guess, not conducive to the thinking that's going to drive the right interventions, then if you're starting from the wrong place, you're going to finish from the wrong place. So to what degree do you think physical therapy and rehabilitation needs to totally change the manner in which they diagnose? Because the reality is, I've seen tweets where it's like, if you're a physical therapist, you need to know the difference between a type 1 and a type 2 impingement. And I'm kind of like, I don't actually think that I do at all. I just think that, like, as long as you have some kind of an idea of how to assess a joint and know what's possible, and you can feel like this is a pathological joint or not, and then you just work around those constraints. So to me, it's like, okay, how do we figure out if this person belongs in my office? And just being able to identify pathology, it doesn't even matter what it is. Like, I don't need to know what the exact pathology is. I think it's more important to be able to identify it, because if you think that's the driver of the symptoms or the lack of function, then you refer out. Now, obviously, it's much less sophisticated to do it that way, and I don't know if it warrants as many classes. But I mean, in your ideal world, like, how do we go about what would be your diagnostic system, so to speak, in the context of rehabilitation, physical therapy, that kind of thing?
Well, I think you actually hit on it in your statement that you said we have to consider what's possible. And I don't think that representation has existed, at least not as well defined in the current system of education that's being provided people in our aspect of care. So when you think about a model that considers things separate, right? So if I look at a muscle and fascia and bone and ligament and tendon and water and fluids and air and all of those things as separate entities that are not, again, like I said before, not as this integrated whole, if I don't consider all those things, then I will lack something in my model that may actually be a source or an influence that is of benefit for me to consider, right? If I look at an isolated structure, like, so I get a diagnosis from, say, a doc, and it comes back and it's like, okay, I have such and such a tissue change or whatever. Okay, if that is truly the diagnosis and it is truly the limiting factor, I can do absolutely nothing about it.
It shouldn't be in your office at that point.
Right. It's like, and so this is the battle that we fight when we do get those patients that do come from a physician with all good intentions, but they give them a label and they say, you have A, and then whatever that A is that follows, then this person comes in and says, I have a hernia disc, for an example. It's like, okay, great. Do you want to see the MRI? No, not really, because it doesn't really change anything from my perspective. It's not that I don't take it into consideration. It's not that it's not an element in the back of my head as I'm moving forward, but that's just a constraint. And then the question mark is it significant enough of an influence that it's going to interfere with our ability to recapture whatever it is we're trying to recapture, whether that is comfortable movement or whatever, which is typical in our situation, why people would come to us. And so, again, looking at what is possible, it's like, okay, does this interfere? If it interferes, and we can eventually figure that out, I think, to enough degree, then we have to also recognize, like, okay, this is beyond my scope. I can't do this, right? And so, again, I think that expanding the model, putting things into a much larger context where everything is working together, provides us an element of that understanding and allows us to look for, and I think you mentioned pattern recognition as being one of these primary elements. That's what we do. That's what, you go to a physician and you have like a sore throat or, whatever. They're looking for signs and symptoms. They're combining those into a situation. They don't know why you have that. They just know that these symptoms kind of go together. This medication goes with those kind of symptoms. And so what we want to do is we want to have a model associated with movement that is similar in respect. Is like, okay, if I see these limitations, then I understand that I have these influences that are potentially creating this presentation that I'm working with. And then how do I alleviate those, or how do I make the influential change to restore what I perceive as what's possible. So I think that again, the restriction comes in the model in and of itself, which is, 30 years into this is totally different from where I started, thankfully. But I think I could have gotten here sooner with a different structure as to how you and I learned. We got an element of it near the end of our educations in the clinic, where you were finally placed into this context in a mentorship, sort of apprenticeship type of model. But imagine how good you could have been had you started there day one and superimposed all of the explicit information and see it demonstrated in real time, in real life from the get-go. I can only imagine how much better you would be coming out as a clinician.
Yeah, and I'm not saying this to be critical of the way that like medical doctors diagnose, because it works for them because they're supposed to be treating pathology.
Right.
I'm talking about the direct access. You're the first person to see this patient with hip pain, and it's like, okay, what's the diagnosis? Well, you get pinching in your hip when you squat. Like, and even with these diagnoses, like, how do we define them, right? Because you can define something like FAI based on an X-ray criteria, but functionally, to me, FAI is, can my interventions get this person to squat without pain? Right. If the answer is no, and I assess the joint and it feels pathological, which is totally subjective and something that right. I wasn't able to detect until I assessed a lot of hip joints, no matter how much I could regurgitate the criteria right. on a multiple choice test. So to me, it comes down to, is it pathological or not? And this is where the trial and error thing, and you talk about this, where you don't know what the diagnosis is until you try something, because based on having treated however many hip patients, if the things that you do that normally work, that get that person to go into deep hip flexion without pain, don't work, and you still feel that same bony end feel when you assess the joint, which is, again, subjective, now you know, okay, there's probably a good chance that this is a pathological condition that I can't influence with my toolbox. And then it goes from a functional construct to a pathological construct. And I just don't know how we rush that. But I think the point of this conversation is that people need to be encouraged that, like, it actually is a lot simpler than it's made out to be, but it doesn't make it easy.
No, because what we do is we actually we have to understand the probabilities, right? So somebody comes in with this subjective complaint of pain in the front of their hip crease, and it's like, okay, well, what are all the possibilities? Okay, so if it's pathological, I'm of no use.
Right.
So I can set that one aside initially, right? And so now I'm just looking at, okay, what influences these possibilities? So based on my acquisition of information from the patient, from some whatever evaluation you use, I determine what may be the limiting factors. I try to alleviate those limiting factors, and again, based on probability. So I have done a number of interventions over the last 30 years, and so I have built up some currency, if you will, in regards to what I think will work under these circumstances, right? And so there's the difference between the first year and 30 years. Is like I just have more stuff. I have failed more times than everybody else, and therefore I am able to narrow probabilities a little bit more effectively than somebody that does not have the task experience that I do. And that's literally what we do, because we have too many unknowns. We can't identify things from the simplest of tests. We can't identify structures in and of on our own. I don't have X-ray vision, right? There are certain things that will be a little bit more obvious than others, certainly. But again, even that's acquired through experience to identify, okay, what is more likely under these circumstances? And so we're always just playing with probabilities, and it sounds like it's a crapshoot, but it's really not. I was talking to our buddy Brian Chung about this, and he goes, but you kind of know when you do something, because the rate of success is so much better. And it's like, well, I'm just better at narrowing the probabilities, because I still don't know what the ultimate answer is going to be. But if I would say that 76% of the time when I do something under these circumstances, I'm successful, I kind of know what I'm going to do. And when that doesn't work, there's a 24% chance that it's going to be something else that I can't do anything about. And that's kind of how we work. And we have to respect that. It doesn't mean that it's like I said, it's not a total crapshoot and it's not trial and error. It's just, that's how you manage complex situations, is you have to understand how to take a piece of information, I intervene, and I take that response as the next piece of information as to how I step forward, and now I can further narrow those probabilities. And then we just go as far as we possibly can under those circumstances. And that's, again, some people would say that, well, that's not black and white enough for me. Well, I'm sorry, but that's just the reality. We live in the gray, we live in unknowns, and we don't even know what all the unknowns are under most circumstances.
So, and that's a great point, where we don't really know, and there's some humility involved, but at the same time, patients come to a medical provider because they want an answer. So, when somebody says, and I'm not talking about like the obvious case where you break your leg in a car accident and that's why your leg hurts, where it's like obvious cause and effect. So in these cases where it's not obvious cause and effect, and it's not like a clear pathological driver, how do you ethically navigate that when a patient asks you, why does my back hurt, or why does my hip hurt? Like, do you say, I don't know? Do you say, I don't even know if that's the right question because it doesn't matter? Because I think fundamentally, it doesn't matter. Like, that's not in my head. Is the why does it hurt?
Yeah, for you and I, it doesn't matter so much, right? But for them, I mean, if you look at the hierarchy of needs of the patient, one of the reasons that they come to see you is they want to know why, right? And I think it's fair for us to say, it's like, we can narrow the possibilities, and then we have to be incredibly truthful. It's like, it could be this, it could be this, it could be this, and if it's this, then I can't help you with that, right? And again, that's why the experiential element of what we do becomes so important and so powerful, and probably why it should start from the get-go, is so that people do get comfortable with that. Because as new students come out, they are afraid to admit that they are unsure, right? Because they think that negatively influences the perspective of the patient. You can be unsure, but you can offer up potential solutions that will be satisfying for that individual, right? If I can narrow it down, it's like, I can't be certain of this, but here's what happens under these circumstances. So as I move your hip into this position and you feel that discomfort, here's what we know. We know that we're closing that space. And so if that space closes too soon for this reason or that reason, then this is something that we're going to be very, very successful with, because in most circumstances, we can address these things very easily. If it's this, this, or this, then it's going to be a much more difficult time, or I need to send you back to the doctor. And this is one of those scenarios where you would refer back out. So I think that's the way that you explain these things. I think that that expresses it with an element of confidence. It's like, I have narrowed it down to these things.
Right.
And I think that becomes a very, very effective way, and a very truthful and honest way to do it, rather than making a leap and saying, oh, it's this, as if everything is obvious. And this is the difference between complexity and something that is very, very simple. And, it's not like if you watch a basketball player come down and for a rebound, he lands on somebody's foot and he gets an inversion sprain, you can speak with great confidence that you've got a really good idea as to what just happened, right? You look at the cardinal signs, and you say, okay, so it's either a baby sprain or it's a really severe sprain. You saw it happen. It's kind of obvious as to what this really, really is. But if somebody comes walking in off the street and they go, yeah, I just had this ankle pain that just kind of started. No, didn't have any trauma or whatever. It just kind of started on its own. That's a totally different scenario that we have to be comfortable with in stating like, okay, here are the possibilities. Here's what we've narrowed down through an assessment. Here's the intervention I would like to do. It's going to give us more information and allow us to be a little bit more certain as to what's going on and whether we can be successful with this or not.
Yeah, I think it obviously demands a level of trust from the provider, because I found that I speculate a lot less and I theorize a lot less about why things hurt. And fundamentally, I'll say, look, like you're here because your hip hurts when you squat. The burden is on me to do things with you that allow you to hurt less when you squat. So without even theorizing about why the hip hurts, it's like, look, let's try a couple of things and you tell me if what we're doing is working. Now I've got my assessments, and you can break things out and you can assess the hip and look for things like more flexion and internal rotation, but why are they there? And I kind of like letting them drive it. And then because I think ultimately it's less so that they want an answer than they just don't want to hurt, or right, whatever their goal is. Like, I can't do X. Well, we have a process to get you from A to B, and you're a part of that process. And ultimately, like, you tell me whether, what we're doing is working or not. And that's where, like, you can't separate the intervention from the assessment, from the diagnosis, because with the right interventions, that becomes diagnostic.
Right.
It becomes therapeutic. And now if the interventions, work, so to speak, now the patient's probably less concerned about why, because you gave them an answer without answering. It's like, well, clearly you can get better without us knowing with 100% certainty what the root cause is, because everybody wants a root cause, but oftentimes right, there isn't. But I don't think I was confident enough earlier in my career to say, look, like, I don't really know. Let's try some stuff, and at the end we can get into the why more. But at this point, it's just pure speculation.
Right. Right. I mean, it's just a matter of being process oriented.
Right.
Versus saying like, okay, what people see is based on their experiences and their perspective. So you're a kid, you fall off your bike, you scrape up your elbow, you kind of know why the elbow hurts, right? Again, we're going back to the obvious situation. What the patient may be looking for in our situations now is they say, well, if I can attach a diagnosis to it, then that gives me the confidence that there is a solution. And what we need to let them understand is that you are now part of a process. And so everything that we do is an element of discovery that gives us more information. We're narrowing, like I said before, we're narrowing our probabilities, and this is going to get us closer and closer to what you might consider the ideal outcome. And again, I think that's a very fair way to do this, and without having to make a leap and to sort of blame something via diagnosis.
Okay, and then as far as like protocols go, because that's a big thing in our field.
Right.
I think initially the intent is like, you don't really know what you're doing, so we're going to give you a protocol. So at week 2 you're doing this, at week 6 you're doing this. Right. But kind of the more you go along, the more you're like, wow, it's actually more confusing to be that bounded by something. So, I mean, and this is always, most of these discussions come down to like, you don't want to be on the chaos side of things. You don't want to be on the rigidity side of things. If you're overly protocol driven, you're rigid. If you have no framework, no structure, no protocol, then you've got nowhere to start from. So how do you think we navigate that? I mean, we've talked about this, and our thought was kind of like, you should have the absolute, like, do not do these things because they're dangerous. So like, hey, for the first 3 weeks after a surgery, don't, do passive range of motion beyond that. But as long as they're not violating those absolutes, everything else is kind of fair game. But I think that it's one of those, it's a centralization problem, right? People aren't comfortable delegating authority because, they don't want to leave all of that gray. But how do we navigate that as far as protocols go? Because it's so overwhelming when you're like, this person's different, this person's different. I mean, right now I'm working with somebody who had a diving accident, has had a cervical spine fusion, has some neurological constraints. And earlier on, I would have been like, what am I supposed to do for somebody who has this level of spinal cord injury? And now it's like, look, I'm not going to magically make that, facilitate that neurological return. That just takes time. That's a constraint. An ACL surgery is a constraint.
Right.
Arthritic joint is a constraint.
Right.
It's easier to see the similarities now, but for a newer person who doesn't have the reps, what kind of guidance would you give them to navigate structure versus autonomy?
Well, you just use an extreme example of somebody breaks their arm. Okay, I have to protect that for a certain length of time, and then after that, I need to slowly reintegrate that element back into this human. But prior to that, there's many things I could be doing. I have 3 other extremities. I have a body. I have other systems that will influence this. And if I can create a favorable environment, then as soon as I am now able to reintegrate that element, in this case, the broken arm, back into it, then I have everything that I could possibly have done in place that will produce a more expeditious outcome as well. And so I don't see any difference in the broken arm example versus any other constraint. And so you take like any ACL repair, it's like, okay, there's certain things that we know about this situation. Okay, so I know that there are certain stages where I need to be a little bit more protective, but beyond that, I have other elements of the system that are trainable to a very high degree under this circumstance. So as long as I respect the protective element and understand graded activities, because that's essentially a great portion of what we do when we're restoring elements, especially in the fitness realm or the return to play, if you will, is that there are so many different things that I could be doing. Whereas if I'm told that like you can't squat, the classic stuffs, or they're saying do this or do that, when there's so many things that could be infinitely more influential. Again, it's literally like you mentioned, it's just a constraint. It's just something that we work around. It's something that we know is an influence that we respect, and then we do everything else that we possibly can.
Yeah, and that's obviously it's a relationship issue between the surgeon and the rehabilitation provider, where I can understand, like if I was a surgeon and you went to school for that many years and that's your good work, right, you don't want people screwing that up. But at the same time, the rehab providers want some autonomy and choice. So I think it just seems like the reasonable middle ground is like, if you're the surgeon, what are the absolute things that you just don't want violated? And then at that point, if you have to micromanage beyond that, you're probably referring to the wrong provider, because ultimately, you can't script out the whole thing. I mean, you can't script the rehab.
Nor is that their role, right?
No.
Right. I mean, that's our role, and to have that understanding, and it would be a great world to live in if you did get an order like that gave whatever procedure was performed and said, just avoid this.
Yeah. At the same time, it's like, as a, physical therapist, I'm not telling the patient, what kind of surgery they should push for when they go to see the MD. It's like the surgeon should know more about that than me. And if they can't make that choice, then I should refer to a different surgeon. It's kind of, so, and there's these relationships that have to be navigated. You mentioned the return to play thing, and it's such a big buzzword, and I don't get it. I mean, frankly, because return to play just means, what did it take to play in the first place? But you had an injury, which is a constraint. So how do we demystify this whole thing? Because it's become it's almost like propaganda at this point, where it's become a meaningless sort of term. And I don't get why all of a sudden, because somebody got hurt, now we pay attention to their preparation, but we didn't before.
Yeah, I don't see the big deal either. Like I said, unless there's some element from a procedure that is unchangeable.
Right.
Right. Those are circumstances. But again, that doesn't really change the game very much at all. Anyway, it's just another constraint to work around. And why is it different? Why is it different when you're 6 months post ACL versus I just came off a 1 month layoff because I just started my off season, right? And so I needed to rest. So again, all we have to do is we have to say, okay, for you to be effective in your sport, I need you to achieve these levels.
Yes.
And that's it. That's literally it, right? Your ability to change direction, your ability to hop on one foot, sprint at a certain rate, produce this much force. I mean, we've always done those things with our quote unquote healthy athletes. And so I don't think it is any different. It's just like, okay, you're just starting from this point A instead of the other point A, and then we're still going to close the gap under those circumstances. I think that again, it becomes very protocolish to say that return to play follows this structure, when the reality is people are going to progress at different rates all by themselves. Yeah. And we have to respect that. And again, it always comes down to that n=1 thing, because if we put everybody on the same return to play structure, it's just like trying to put everybody on the same program and expecting everybody to have the same outcome, when the reality is it doesn't work that way.
Yeah, I'm not trying to say that like getting a hip surgery versus a knee surgery, there aren't unique things with each of those procedures, but no one ever acknowledges the similarities, right? Because if you're a midfielder in lacrosse, whether you got a hip surgery or an ACL surgery, ultimately your sort of program or your scheme should funnel into the same thing. So it's just different in the beginning. But what we see all of these, like these linear things, none of which are connected. But if we're talking about return to play and protocols, like no one's really talking about, okay, like there's different constraints in the beginning, but they ultimately have to converge based on the demands of the game. The demands of the game dictate return to sport. But it just seems like we're reinventing the wheel anytime somebody has a procedure, because we haven't really defined, well, what does it mean to be prepared in the first place? And maybe we're just, because when people are healthy, we just assume, well, like we're lucky they can play, so they're good. But we haven't really thought about like, how do we know they're ready to play? And these are things that require, I think, a blend of objective and subjective.
Right.
Yeah.
Yeah. I mean, again, when things go successfully, we don't ask enough questions.
Yeah. Yeah.
Right. And what we really need to do is establish a process, and that process does not have to be unique. It just has to respect what the constraints are. And so people that are apparently healthy still have constraints. They still have secondary consequences associated with everything that they do. So not all things that we apply are good things under every circumstance. And again, we've always respected that from the fitness side of things, if we can call that, preparing an athlete for their sport in general. But it always seems to be a little bit more special when they're coming off of a rehab situation, when the reality is it's really the same rules.
Yeah, and I like what you said there. And it comes down to process, because when the outcomes are good, which in the context of rehabilitation is the guy didn't get hurt, the girl didn't get hurt, right, we think that we did a good job. But right, and conversely, people can get hurt and you could have done everything right. So yep. I'm not saying outcomes aren't important, but like the aviation world, the military, like they're debriefing after every mission, even the successful ones, and they're trying to refine the process, which probably doesn't happen enough in our field.
What can we, so when you have the ideal outcome, what could we have done better?
Yeah.
What did we do wrong? Was there some place that we could have saved time? Is there something else that we could have done and gotten the same outcome? Like these are the questions that we ask when we screw up or when things don't go as planned. When the reality is if we ask, just make it a process and not look at things as like, oh, this was good or this was bad. It's just like, this is just what was. It doesn't change the way that we should perceive these things. We'll be much more successful. We'll have many more answers. Most likely, we'll be able to narrow the probabilities even better than we did before. And then we can apply these things regardless of circumstance.
Yeah, and I think that we probably overreact when things go wrong and underreact when things go well. And it's like somebody gets hurt, so we have to totally abandon everything that we've been doing. And if you have enough trust in your process, you're going to realize that like you probably are going to take some casualties, so to speak.
Right. It comes down to decision. It's decision making, which again, decision making should not be based on on a successful outcome or a failure. It is a process that you utilize to make a decision. So you could do everything perfectly and people have a horrible outcome. You could do everything incredibly poorly, and that individual, for whatever reason, overcomes that and still appears to be successful. And so again, it comes down to refining your processes. And that's where we need to be focused on. It's not the good or the bad. It's like, how did we arrive at these decisions? And then if we get better at making decisions in general, we will tend to have better outcomes.
Yeah, there's no better reminder of that than what's going on now, where with this virus, right? Like there's so many unknowns. So we don't even like know what the outcomes are, because you can give somebody an antibody test or an antigen test. We can't even necessarily trust the results. So it's really about like looking at processes under uncertainty, and we don't even know like what the outcomes are going to be, because this is such an evolving process. So
but again, so there's a key word right there. It's evolving. It's like,
yeah.
So every time we get a new piece of information, we have to take that into consideration and then say, okay, how does this affect our perspective, and how does this affect what the probabilities are? Because again, we're Mike Russell bought me a book not too long ago from Annie Duke, who's a professional poker player, and what she's talking about when we're making decisions is says we're playing poker, we're not playing chess. Chess is very structured and has very defined outcomes. We're always playing poker. So we always have a probability that we have a desire for and one that we probably don't have a desire for, and both are still on the table. So even though I might have a 76% chance of having the outcome that I desire, there's still a 24% that I won't. And it doesn't mean that you made the wrong decision if you fall into that 24%. It just means that there was a lot of influences here. There's a lot of factors involved, and luck is a real thing. And so again, you could do everything right. You can make the best possible decision and still fall into that 24% failure.
Yeah, you could have a 19 in blackjack, and if you don't get another card, you could lose, but yeah.
So that's unfortunately what we're playing. But again, people are uncomfortable with that because it's in the gray. And we do have to learn how to get comfortable with that, because that's literally how we work.
Yeah, I mean, it's easy for us to do that because we work for ourselves. We don't have to answer to anybody. We don't need like these BS metrics to, justify it. And so I get in hierarchies and larger organizations how this becomes problematic, because we kind of work in a utopian environment. Right. So I'd love to hear your thoughts on breaking down some of these various models or martial arts, so to speak, in our field. So kind of like, if you were to ask Bruce Lee, what do you like and not like about judo? What do you not like and not like about Western boxing? So let's start with, our field. I consider kind of anatomy a model or a pillar. That anatomical model, and I know that you've got some passionate thoughts on this. So what is anatomy good for and not good for in the context of rehabilitation, performance, that kind of thing?
Well, so I talk about dead guy anatomy as a representation of how we actually move, and that's just not reality. It is a representation. It is unfortunately not the representation. When you're looking at a cadaver, and because of I mean, all you got to do is ask somebody, like, what are you made out of? And they go, well, you're like 2/3 water. It's like, okay, well, that's a big deal, right? I've never worked on one of the fixed cadavers that had any water in it whatsoever. And beef so jerky. Right away, huh?
Oh, beef jerky.
Yeah, exactly. Yeah. So right away, my perspective is different. So I look at these things and I say, oh, look, if I pull on these things, there's a bunch of levers there. And so then we get the lever model that's associated with that. So then I immediately have a type of math that goes with that to calculate forces. Well, here's the problem with that. That ain't reality. Not even close. And so now I have a misrepresentation of how these things actually work. And therefore, when I even do calculations, so if you look at the biomechanical model, and they use typical geometry to calculate out forces that exceed the tissue tolerance. All right. So it's like I remember if you're in the NBA and you perform a slam dunk and you land on the ground, I can't remember whether it's 8 or 16 times body weight is the force. How on earth could you possibly withstand that if we're using normal geometry? So we don't behave that way. And so again, those forces are misrepresented. And so again, if we're making decisions off of that type of a model, then we started with the wrong model. Our decisions will be wrong under many circumstances. It doesn't mean it's not useful under some circumstances. It just means that under reality, it's just not. And so again, I prefer to try to use something that it's a little bit closer to what we actually are in regards to dynamics, which is the compressive and expansion element of how we move through space, and we're much closer to, I suppose, a worm than we are a cadaver in regards to how we actually behave, which means that then the anatomy needs to be learned in context. So we touched on this a little bit earlier. This is why, going through a semester of gross before you do anything, again, it's nice to know where stuff is, but I could have an app for that. Yeah. I don't need to spend hour upon hour dissecting out when I could just say, okay, this structure is here, because when I do my little highlight thingy on my app, I know exactly where that is. But now move me into a context where I have somebody that is actually behaving in space, and now I can say, I can see how this now relates. So again, much more useful representation than to lay somebody on the slab and like I said, pulling on tendons and saying, this does this, so we're going to call this, it bends the toes, so we're going to call it flexor digitorum, right? Which again, not very useful, especially when it's out of context, because that's not what it really does when you're walking across the ground.
Yeah, I think, sorry, go ahead.
No, you go.
No, I mean, with regards to anatomy, I just look at it like there was a point during my first semester of PT school when I could literally identify every muscle, nerve, blood vessel in the body, right. And I would heinously fail the written or the practical exams now, and yet I've been treating and I feel much more competent clinically. So if what we're learning in that setting is truly useful, it should be reinforced, and if anything, enhanced when you're actually applying it. Right. The application of that anatomy made me know the cadaver stuff less. So even when it comes to things like manual therapy, if people are into that, and we'll talk about that later, I don't want to get too deep into it, but it's like to do a manual therapy technique, I don't need to necessarily know what that's called. I just need to know, like, I can feel some kind of aberrant tone and I'm going to do a technique. And as long as I know, like, that I'm not on something that's really bad, like if you're dry needling somebody, you don't want to dry needle the sciatic nerve, but does it matter that you're identifying which deep hip rotator you're on? Probably not, except for it allows us to speak a common language. Right. But I just don't know, and to your point, I think that in terms of opportunity cost, cadaver anatomy is just not a great use of time and resources when you can use an app. I think for like a surgeon, if you're trying to do procedures on actual anatomy on people under anesthesia, that's a different story. But it's a rite of passage, and it's a way to select people. It's kind of like in the military, because you have an untrained person, the way that they weed people out is they make you crawl through mud and run around with logs. But it doesn't have actually, once you're a qualified soldier, so to speak, before guys are going to Afghanistan or Iraq, they're not running around with boats on their head and crawling in the mud. They're doing things that look like their job. And I think anatomy is just an imperfect proxy for selecting people that have the determination to make it through a medical program. No, I'm serious. I think I'm trying to find something good about it. I think that's what it does. It's a rite of passage. But as long as we're like acknowledge that, and we're not, we're agnostic, and we're not saying like it's really important, because to your point, if we embrace that model too much, I think it can lead us astray.
Right. And again, it's like it's not that it's not totally irrelevant. It's just that its level of relevance is limited. And just like any model, all models have a limitation. Right. It's like, okay, so this is a representation of something, okay? But again, it ceases to be useful very, very quickly, right? And I think there are better ways to go about this, especially when, we don't work under those circumstances, right? We have to have people that are alive and moving and working against gravity and forces and et cetera, et cetera. And so again, that would be a much more useful representation if we would emphasize that. It doesn't mean the anatomy is not important, but again, like learning it structure by structure by structure,
Right.
probably not terribly.
In the kind of depth that we have to learn it.
Yeah, yeah. It's like, I did flashcards for every muscle and nerve and, all through school just so I could get through that, because you have to memorize it. You have to pass the test.
So related to anatomy, the next thing would be biomechanics. If we talk about anatomy as kind of like, just statically what's going on with the body and the structures involved, biomechanics is sort of the movement or positional manifestation of that anatomy. Now, there's a whole gamut of things, right? There's like the posture police, where it's like, if you have a plumb line and you're deviating from the plumb line, it's causal of all these things. But then you look at some sports, and while people have idiosyncrasies, there's certain mechanical sort of truths that emerge. So how are biomechanics useful and not useful to you clinically or in a performance setting?
Well, so it's representative of the possibilities, right? So all I have to do is I have to have a representative model of what I'm shooting for, right? So again, the biomechanics are that representation. It's like, how do you know when movement is better? Besides the fact that the patient says, "Oh, that's better. It feels better." Do I have a representation that can provide me some measure of information to know that I'm on the right track? So what if if I recognize the fact that, okay, so based on my normative model, full motion has been restored, this person still has a complaint, then that might just be one of those representations that's now beyond my scope, right? So I have to have those elements. So biomechanics provides me that foundation of understanding of like, okay, under most circumstances, this is my norm that I'm comparing what I'm seeing to. Right, and again, it is foundational, whether you want to appreciate it or not. And I would say that from the biomechanics standpoint, is using it as that representation of what is possible, not as a singular representation. So when you talk about things like, oh, does posture matter? Yes, it does matter when it matters. Right? Does a posture represent an absolute that someone will feel a certain way? Absolutely not. That'd be ridiculous to say something like that. But it may provide a piece of information in certain circumstances that becomes valuable, especially when we're talking about the ability to change, which is, making people more adaptive tends to make them feel better. And so if I have somebody that has a representation where they demonstrate a lack of adaptability, and it just so happens that they show up in a certain shape, that might be useful, right? But I can't rush out on the street and go and start pointing at people and go, oh, you have this, you have that, you have this. That would be kind of silly, right? So again, it's just information, and we have to respect where it is valuable and where it might not matter.
Yeah, and you said it doesn't matter until it matters, and you don't know if it matters or doesn't matter until you try things. So
again, we're back to the intervening assess, right?
You can be overly deterministic, but also overly nihilistic, because to say that it doesn't matter, I think, is also flawed as well, because you actually know that it doesn't matter.
Right. It's just information. It's just information. Is it useful? Maybe not right now. Is it useful later? Maybe it will be. Maybe it won't be. I don't know. It's like I'm totally comfortable with that fact that, okay, it's just a piece of information.
Yeah. Right. I think that there's kind of a counterculture to biomechanics, because probably for the most of the history of PT or rehab, it's been overly deterministic, and so the reaction to that, and maybe this is one of those things where you have to have an overreaction to meet in the middle. I hope that's not true, but that just seems historically to be the case. So now we have the pain science. Yeah. So in your opinion, is there anything particularly special about pain that it warrants its sort of own science, if that's even a thing? And again, I think there's good things about it, but what do you take from it that's good, and what do you sort of disregard?
Well, I gotta steal something from Naval Ravikant when he was talking about, if you got to put the word science in the title, it's probably not a real science, right?
That's true.
all we're talking about is an element of the human's physiology. So the pain science is no different from happiness science or any other anything you want to attach to it, right? It is an element that is an influence. The reason that pain gets so much attention, and I've said this a gajillion times, is because it's an unpleasant sensation, because we don't study we don't study joy the same way we study pain, right? I'm sure they do study joy to some degree, right? But pain gets a lot more attention because it interrupts things to such a degree, and because of its unpleasant nature, we want to get rid of it. But if we keep looking at it as if it's something that is so different from everything else, then I think we're going to be lost. What we want to look at is like, okay, when somebody has these situations, what are these adaptations? How does the system behave? What are the possible influences? But again, these are the same questions that I asked before, because it's just part of the process of this whole thing, right? And so it's not that I would ignore it. It's not that I don't value it, right? But again, it's just another piece of the information that lets us know the status of this situation, right? It allows us to help. It helps us make decisions, but we can't. So, for instance, based on our scope of practice, people come to us because they're in pain, but our scope of practice really doesn't set that as the direct outcome, because we are movement related in our scope. And so once we have a representation of everything that we can possibly do, if the pain persists, that is no longer our situation, right? And so they may need some other form of intervention to resolve that situation. And so again, it's just, like I said, it's just a piece of information. We try to understand it the best that we can. We try to understand how it influences the situation, but it is, again, one piece of information.
Yeah, I mean, it's another constraint, just like getting an ACL surgery that we have to work around. And the reality is it's subjective and very poorly understood. So right. I think overly focus on it can be problematic, because what is it that you're chasing? And moreover, like, if your identity as a movement professional is to work on functional outcomes, then how do you maximize function with pain as a constraint, right, working around it? I will say that what those sort of models and constructs did for me was they made me more careful about what I should avoid saying to people. Right. So you don't want to tell somebody, oh, well, you've got the back of a 90-year-old, even though you're 20, right, because that obviously creates a ton of potential problems, and then people internalize these things. So I think that, it did reveal some of the deterministic flaws in the biomechanical model, but if you take the pain science model too far, and now you're giving lectures for an hour about ion channels and just talking, but you're not doing things with people because they still need to be able to move and do things. That's why they're in your office. I think you can take either of those things to the extreme, but I think the key takeaway from that model for me was, at least, like, I'm much more careful about what I say, and more importantly, what I don't say, because what we say can have, very profound consequences for people.
Right, and again, that's just understanding, like, okay, right, how does this influence this situation?
Right.
Right.
And that's not unique to pain. I mean, pain science people are emphasizing that, but it's not necessarily unique to pain science. But I think that in the context of our field, they're the ones that are most, kind of championing that message, and I give them credit for that.
Absolutely. I like you said, don't deny it. We've been through many situations, together and on our own, and again, seeking out those resources for that reason. It's like, I need to understand how this is an influence. I need to understand where this is most valuable. I need to understand how to manage this, but I can say the exact same things about everything else that we have talked about as well.
Yeah, and I mean, since you're bringing that up, I'll admit, when I goofed up with you when I was your student, it was when I was just reading this stuff and probably being a little bit too enthusiastic about it. And we had the one patient with a really arthritic hip who needed a hip replacement, and telling him about his amygdala and all that, it actually backfired.
Not very helpful.
And that's more
again, it's a powerful lesson. It's a powerful lesson learned.
Yeah. So then, moving on from biomechanics, pain science, I think kind of a hybrid of those two things is the just load it model, where kind of the idea is, everything is a matter of progressive overload. It doesn't so much matter how you do something as just, you need to develop your tolerance. So the extreme example of that would be, deadlifting a maximal weight. You can do it you can try to, in your setup, maximally around your lumbar spine, as long as you progressively build up to it. Right. Again, I think there's good things about it, because you are emphasizing progressive overload and not being overly deterministic about biomechanics, but I think it neglects biomechanics. So where are you on the just load it? Because to me, it's like, all right, well, load what? Because
Okay.
in order to determine what it is that you're loading, you need a biomechanical or how component.
Right. I mean, so if we're talking about graded activities and things like that, I think that's a little bit more straightforward than to I think when you talk about, oh, you just need to get strong, or I don't even know what that means anymore, to be honest with you, or to just put load on it. The thing that we have to understand though is that when we are focused on one thing, that there are secondary consequences associated with everything that we do. Yep. And so what are the secondary consequences of increased force production? So let's just call it force production for the sake of argument, because that's a little bit more of a measurable concept versus like gym strength or something like that. It's like, what are the secondary consequences of that, right? And so again, so I have tissue tolerances that I have to consider. I have strategies that I have to consider. So I have behaviors that are associated with me producing force. So I will produce force in very specific circumstances, in very specific ways. And so if my intention is to load a tissue to increase its resilience or to enhance that structure, what are the secondary consequences? Did I take something away from something else that might be just as valuable if I'm talking about health or if I'm talking about performance? Because there are many situations in performance where we slowly take things away from someone because you cannot raise performance. It is a very rare situation that someone would be great at everything. And so let's just simple gym strength or something like that. So if I raise your squat from 300 pounds to 400 pounds, what did I have to take away from you to do that? Did I take away something valuable in regards to your ability to move? So for instance, if I have to sacrifice shoulder range of motion or hip range of motion to get you to bench press more or squat more, was that useful? Was it helpful, or was that secondary consequence a negative? So we have to be very, very careful in how we describe these things, and we can't have that singular perspective of, oh, you just need to get strong, because again, there are consequences to that may not be favorable under every circumstance. In some situations, it may not matter, and in other circumstances, it may matter a great deal. If you took a golfer, and you took away their ability to turn because you had to make them more stable to lift a heavy deadlift, that's probably a bad idea. Okay. Yeah. You raised their strength. So you loaded them, you raised their force output, but now you've also created a consequence where they can no longer access a position that they needed to perform. And now maybe you're going to put load on structure, or maybe they're going to create some sort of compensatory activity. And so maybe you just created a secondary consequence that's unfavorable. So I don't have any issues with the concept of loading. I just think that we need to be a little bit more broad in our perspective as to what's actually happening under those circumstances. And it's not just that aspect. Like everything that we do has a secondary consequence, right? Me reestablishing someone's range of motion can reduce their force production.
Sure.
Do they need that to protect themselves? So I always have to consider these things. Right. So that's why you have key performance indicators as you're moving someone through a process, whether they be a rehab patient, whether they be an athlete that's training for performance. We have certain elements that we say, I need to make sure that I maintain this because it is representative of their resilience, or it is representative of their ability to produce more force, which is what I wanted in the first place.
Yeah, and I think where it gets tricky, because I think to me, like my interpretation of the just load it movement is that the execution doesn't matter so much as the progressive overload, yeah. But it becomes difficult when you're trying to differentiate symptom relief from performance. And because it's a functional profession, we're trying to achieve a functional goal, which is performance, but we're also trying to reduce symptoms. So it's not clear. Well, it's not a line, right? It's a spectrum. So like if you've got someone who, let's say, they just want to be able to run once or twice a week without pain, go for a 3-mile jog. They don't care about how fast they are. They've had no pain. If that person comes in, do I care how they run? Probably not. But if someone, let's say, has had a history of hamstring strains and they want to run at max velocity, right, I'm going to care a lot more about how they do it, because if we look at the best sprinters, yes, there are idiosyncrasies among individuals, but there's also certain biomechanical patterns that emerge, right? So I think you have to look at the individual, and again, it's trial and error. Like it doesn't matter till it matters, and you don't know until you try, which is not satisfying, but that's the grade that we live in.
Yeah, it's always going to come back to that. Every discussion like this is going to come back to that. It's like, okay, yeah, there's probabilities. Yes, it's gray. It's n=1, right? It's like, what are your needs? What do you present with, right? And again, people want black and white answers. It makes them comfortable, and we just need to get used to being uncomfortable and be satisfied with what we are capable of doing.
Yeah, and I think reducing any complex human interaction to a hashtag is comfortable because it's like, oh, we haven't figured out, but none of these things,
Right.
treatment is not a hashtag. Um, we're kind of, I'm coming up on time here, but what do you think for you? I mean, throughout your career, you've had periods where you've like really zoomed in and gotten very like rehab movement centric, and then periods where you're zooming out. For you, I mean, I'm sure it's kind of more of a subjective thing, but like, what makes you determine when you're going to do what?
It's kind of like, I hate saying this, but it's just kind of like how the river takes me sometimes, right? And there's certain things that capture your curiosity infinitely more so than other things. But I think that the reason that you do go in and out is because you're trying to say, it's like, okay, how valuable is this? And then you're not certain of that. Or like I said, just sometimes it's just fun. And that's acceptable, right? To just dig into something and really, really get a grasp on it. And I think that having been involved for 3 decades, the way that I learn now is just totally different from what I've done before. I actually picked up, what's his name, Michaud's Human Locomotion book this week, which is like a technical book that I haven't touched in.
I heard that it's great though.
Yeah, it's a great little book. It's like, and again, that's why it's still on the shelf. But it's like I just grabbed it because I had a question about something, and I just needed the technical side of things. But I think that the further you get into this stuff, and you start to layer upon layer upon layer, on, again, like I was talking about, expanding your base of analogy. There's a certain element of like, what else could be an influence here, and what am I most confident with, and do I need something else? And looking at the way that I've evolved my model over probably the last 5 years, 6 years, and you've gotten a taste of it because I used to send you, a bunch of stuff on a regular basis as to what I was digging into at the time, so you saw some of that evolve. But I think that you have to dig into certain things to say, is this valuable? Does this fit? Is this in conflict? And so you have those questions that you have to answer. And so that's when you do kind of dig in, and then you kind of zoom back out and you say, okay, so this is the whole thing as a representation, right? Where are the gaps? And so a lot of these things are identified as I teach. So again, having had 25 students over the last 8 years or so, every time you teach something and you teach it a little bit differently, and you say something out loud or they ask a question, it allows you to say, oh, you know what, I need to look a little bit deeper into that. And so then that's your zoom in, and then you kind of zoom back out and you say, okay, how does this affect everything else? And so I think it's always going to be this back and forth kind of a thing.
Yeah, and you kind of touched on it, talking about other things and models where everything comes at the expense of something else. So I think zooming out actually allows you to connect the dots, get that BS filter, but you need dots to connect, and that's the zooming in. Right. I just found, like, for myself personally, to your point, like, I just do what I enjoy and what's going to be fun. And, when it comes to learning and anything else, because if you enjoy it, you're going to retain it. If it's being imposed on you, like, which it often is in an academic environment, like, where it can just drain the joy out of learning. Right. I find that I just, like, anything that's important that I've retained, I didn't ever study for.
Right.
Right. And that's kind of happening now. Like, if I want to read something, I'll do it. And I used to kind of, if I started a book, I had to finish it. Now, if I start a book and I don't like it 10 pages in, I just stop. Right. And, like, I don't feel guilty about that anymore. It's really the enjoyment. And like you said, it's kind of going with the wind, which, would have been very unsatisfying earlier in my life to have somebody tell me that. But I think maybe you need a little bit of a base before you can even gauge where the wind is blowing, so to speak. But that's kind of the evolution of it.
Yeah, but like I said, the nice thing about learning is that there was always something else, right? Yeah. There's always a next, and a patient might say something to you, or a colleague might say something to you, and then that leads to curiosity, and then that leads to interest, and then that leads to the active investment of, you know, acquiring the information. And then it's like, okay, does this fit? Does it not fit? Do I need to spend time on this? Do I not need to spend time on this? And again, that I'm in a constant state of that. I think we're always seeking, right? Because we're always curious and we always want to know what's next. And the thing that would challenge people is don't just follow the current, because that's a really bad way to go. Is just doing what's popular, because while it may be useful, it also leads to just what I call lateralization of information. It's like people learn things that are not in depth, and then they pass that information on, and then it becomes the world's worst game of telephone. And you know, I've said this before. It's like you make a photocopy of a photocopy of a photocopy of a photocopy, and then by the time you get, you know, 10 of those deep, it's just very unclear as to what's really going on. And so I would prefer that people sought out the things that they are interested in, that they do find useful, and not say that, oh, just because this is novelty, this must be important, right?
Yeah, and I think it's a little bit of like, you know, David Epstein talks about this in Range and even in Sports Gene, where, you know, obviously you don't want to have no structure, but I think that our culture is very, very structure grind. You need to know what you're doing and have a linear path. And maybe what a lot of us could benefit from is just being okay being directionless. You know, and
Yeah.
I think, and maybe in a culture that was like a little, you know, kind of the opposite, that didn't have any direction, then maybe it's better to be told to have more structure. But like, I don't know, we're in a culture that celebrates getting up at 3 a.m. and stuff like that. We probably could benefit a little bit more from like, yeah, just kind of go with the flow a little bit. And then if you do it, then you can rein yourself back in.
Yeah, nobody has to tell you what to study.
Right.
They shouldn't have to tell you what to study, right? You should just be interested and then seek things out. And then, you know, it's like you if you want to go buy a shirt, you try on a shirt. If you don't like it, you don't buy it, right? Yeah. If you like it, maybe you get another shirt. So it's kind of the same thing. It's like, okay, I study this. It's like, is this useful? Is this helpful to me? Or is it just a curiosity? You know, I'm reading about quantum physics. Okay, how useful is that to me? Well, maybe it is. It helps me think a little bit differently about things. And so then it becomes useful. Am I going to directly apply it as, you know, am I going to be concerned about what particle is flowing through me at the moment? And it's like, no, not really. Right?
Yeah, well,
it's like, where is that useful?
That was a lot of fun. It flew by. I've got to put my mask on over here and thanks for coming on. I mean, we've been wanting to do this for a while. We probably had so many conversations we wish we'd recorded, and
yeah,
we got one. So
yeah, it was fun. Thank you for having me, Doug.
Yeah, absolutely. Thanks. Enjoy the rest of your weekend. Bye.
Hey, and thanks for listening to the Resilient Performance Podcast with Bill Hartman and Doug Kechijian. We'd like to make one quick announcement. Our Movement Foundations course in its online format is currently on sale for $100 off, and the sale is going to be ending this Sunday, May 31st, 2020. So we hope that you take advantage of the discount. It's the biggest one we've ever had and might ever have. So hopefully we see you on there, and look forward to seeing you next episode.